start directly. So we all can be on mute and monitor.
Yeah, so within next 10 seconds, we will go live.
We are ready.
So it's 5, 4, 3, 2, and 1. So we are live now. We can start our session. Over to you.
Are we live?
Yeah, we are live. You can start. Over to you.
We are ready. So good afternoon, everybody. So on behalf of All India Coordinating Committee of North Zone, Royal College of Obstetricians and Gynecologists, Association of Obstetricians and Gynecologists of Delhi, and National Association of Reproductive and Child Health of India, Delhi branch, I welcome all the faculty and delegates for joining this most sought after webinar on intrahepatic cholestasis of pregnancy. This topic was chosen because it takes us to many crossroads with decision dilemmas every day. The disease that was earlier seen in the late second or third trimester is now being seen earlier and earlier in pregnancy. In India, we are aware of our increasing incidence of non-alcoholic fatty liver disease in up to 30% of the general population. The contributing factors may be obesity, insulin resistance, and diabetes, the carbohydrate-rich diet, high triglyceride levels, etc., etc. Now, on top of it, COVID is complicating it further. With this background, for an in-depth and comprehensive discussion on the subject, we are honored to have none other than the foremost authority on the subject, Professor Catherine Williamson. Professor Catherine Williamson mesmerizes the audience with her knowledge of the subject and her logical approach to the management of intrahepatic cholestasis, based on her years of experience, of which she has been an integral part. Her research focuses on the endocrine signals that influence alterations in bile acid, lipid, and glucose homeostasis in normal and pathological gestation. She also studies the maternal and fetal etiology and outcomes of intrahepatic cholestasis of pregnancy and gestational diabetes mellitus. Today's webinar starts with a talk by Professor Williamson. This will be followed by a case-based discussion in which our expert, Professor Williamson, will be accompanied by our 6 eminent panelists from government institutions as well as private hospitals. I welcome them for joining us today to discuss the difficulties and solutions in intrahepatic cholestasis of pregnancy within the available resources. This will certainly make the discussion more meaningful. The moderators, Dr. Sangeeta Gupta and Dr. Jyoti Bhaskar, for the case-based discussion, need a special mention for their insights into the subject. They bring with them cases to cover varied and diverse situations and are sure to provide some interesting scenarios for today's discussion. In the end, we will have question and answers. I request the delegates to kindly write your questions in the chat box to the side so that our faculty, Dr. Angela Neja and Dr. Neeta Kaul, can bring them to the discussion. Now, without further ado, to commence Professor Williamson's talk, I invite chairpersons, Professor Kamal Bakshi and Professor Achla Batra to introduce the session. Professor Kamal Bakshi is Professor Emeritus, National Academy of Medical Sciences. She is former head of the Department of Obstetrics and Gynecology, All India Institute of Medical Sciences in Delhi. She has so many firsts to her credit in her field. Professor Achla Batra is the Director, Department of Obstetrics and Gynecology at Vardhaman Medical College and Safdarjung Hospital, Delhi. She is the current President of Association of Obstetricians and Gynecologists of Delhi. I will now hand over the screen to Professor Bakshi.
Good afternoon, everyone. My sincere thanks and gratitude to the charming and knowledge clinical head, Dr. Ranjana Verma ji, for giving us this unique privilege of virtually meeting the smiling queen of science, Professor Catherine Williamson. She wears the glittering crown with rubies and diamonds of her excellent achievements. She is the Professor of Women's Health at King's College London, Fellow of UK Academy of Medical Sciences, and a Senior Investigator of National Institute of Health and Research. She has researched the causes, complications, and treatment of intrahepatic cholestasis of pregnancy. Wow, for more than 20 years, my dear. Being a legend and a dynamic researcher, she leads clinical trials on ICP and gestational diabetes mellitus to improve the outcome of pregnancy. Professor Catherine William not only will enlighten our path, she will really do the inroads of the dark forests that exist as far as the intrahepatic jaundice is concerned. She'll be speaking on evidence-based management of intrahepatic cholestasis of pregnancy. Dear Madam, your pulse of wisdom will pave the way for early diagnosis and management at rural, district, and cities of India with either little or no or significant resources to improve the women's and fetal health. My namaskar to Professor William Catherine.
Thank you so much, Dr. Bakshi, for this very, very kind introduction, and Dr. Sharma, and to the entire committee for inviting me to speak. Shall I share my slides now? I am delighted and honoured to have the opportunity to speak to you all. And for the next 45 minutes or so, we'll speak about obstetric cholestasis, also called intrahepatic cholestasis of pregnancy. I will just ensure that my slides will, there. So intrahepatic cholestasis of pregnancy, as you know, is a relatively common gestational disorder. It is the most common gestational liver disorder in women of white European origin. It affects about 1 in 140 pregnant women. But as you will know, the condition is commoner in South American women, particularly those of Andean origin, and in Asian populations. And in some of the recent studies from India is quoted as affecting probably a little bit more than 2% of pregnant women. But of course, the proportion will depend on how the condition is diagnosed, whether serum bile acid measurement is available. And if it is, I would say that the most important group to consider, and I will discuss this through the talk, are those with serum bile acid concentrations greater than 40 micromoles per litre, and that is around about 25% of pregnant women with cholestasis of pregnancy. This is of relevance in particular to the risk of adverse pregnancy outcomes. So through this talk, I would like to speak about new and existing data, including some new genomic data and evidence for performing genetic screening, considering what is the cause of itch in cholestasis, the causes of adverse pregnancy outcomes, and which biochemical tests are helpful for prediction of women whose pregnancies are at risk of stillbirth or spontaneous preterm birth, and then a consideration of the data we have relating to treatments, existing treatments, and possible new treatments. Before talking about genetic changes, I want to remind you of what most of us learned when we were undergraduates. Bile acids are made in the liver from cholesterol, and this is the main way that cholesterol is eliminated from the body. After bile acids are synthesized, they are conjugated with either glycine or taurine to become bile salts. They're then transported into the biliary tree, stored in the gallbladder, and released at the time of ingesting a meal. And the traditional known function of bile acids is to assist with lipid absorption. And in the terminal ileum, the majority are then reabsorbed and transported back to the liver in the enterohepatic circulation. About 5% are lost every day in the feces, and they are replaced by new synthesis from cholesterol. Anything that can obstruct the intrahepatic circulation can cause cholestasis. And this can be from an extrinsic pressure, such as from a tumor. It can be caused by gallstone obstruction. But in the context of pregnancy, it is typically caused by a molecular change in one of the biliary transporters in the liver. So I'm going to move on to a summary cartoon to explain what the mechanisms are. And the reason for having this is I can then tell you why we're interested in some genes that may be of relevance to your patients. So this schematic represents hepatocytes. Here we have the cytosol. So this is a liver cell cytosol. And then this is the canalicular membrane across which bile constituents are transported into the bile canaliculi. And in the lipid membrane, there are 3 transport proteins of particular interest in the context of cholestasis. Here we have the bile salts that have been synthesized in the liver, represented in red. They are transported by a protein called the bile salt export pump, or BSEP. You can see in the box on the left, the gene name is ABCB11. And the names really aren't too important, but this is the main bile salt export pump that transports against a concentration gradient to transport bile salts into the bile and the bile canaliculi. Bile salts themselves are detergent molecules, so they're harmful to hepatocytes and they can break down the membranes of the biliary tree. So they are contained within mixed micelles surrounded by phospholipids. So for effective formation of bile, it's also important to transport phospholipids. And one of the most important proteins for this is shown just below the bile salt export pump, represented by the name MDR3. The gene name is ABCB4, but essentially what this is a protein that blocks phosphatidylcholine from the inner to the outer leaflet of the membrane and then into the biliary tree and the canaliculus where it forms mixed micelles. And to allow this to occur effectively, other phospholipids have to be flopped back across the bilayer. And one of the main proteins that does this is shown at the bottom, FIC1, also called ATP8B1. So these are the 3 main proteins in which mutations have been found in familial cholestasis. So we also studied them in women with ICP, as have others, and a number of mutations have been reported in them. In the next slide, I'm going to show you a table that summarizes some cases. Please don't worry about taking in the information from a busy table, but I wanted to show you this. Firstly, to show you that in this study that was reported a few years ago, these 3 genes that I've just told you about were the main ones in which mutations were found in women with cholestasis in pregnancy. The table otherwise, the detail you don't really need to look at, shows the extent of the elevation of the liver transaminases, the bilirubin, the bile acids, and some of the medical and obstetric history. But that's summarized on the right. And in essence, when these women presented and were recruited for the genetic studies, we asked about their medical history. About 1/3 of them had gallstones, and these are young women of reproductive age. And quite strikingly, 2 of them had cirrhosis. When we asked about their 1st-degree relatives, about 1/3 of them had gallstones, and a similar proportion had cirrhosis. So I think this is important to note. I suspect the genes that make women susceptible to cholestasis in pregnancy make them and their relatives susceptible to more serious hepatobiliary disease when they're not pregnant. And as you would imagine, these cases had the same spectrum of adverse pregnancy outcomes that are reported with ICP, and I will come on to talk about later in the talk. So at the time we were doing this study, we were very fortunate to be selected as one of the groups that would contribute to a national UK study that was evaluating the use of whole genome sequencing within the National Health Service. And it was really trying to establish whether this can be delivered and whether it is worthwhile. So I always have to thank all the centres that gave us samples for this study. For the cholestasis study, we recruited women with disease with onset before 33 weeks of gestation and where the mother's serum bile acid concentrations were at least raised to 40 micromoles per litre. We did the whole genome sequencing on over 300 women, and we initially evaluated what we described as tier 1 genes. These were the genes where there was already convincing evidence that they could contribute to cholestasis. So the 2 we chose were the phospholipid transporter and the bile salt transporter, the first 2 I told you about. It was a fascinating process. And for any of you that may be considering this, we had to consider whether we were going to report potential genetic changes to clinicians that were truly pathogenic. So to do this, we formulated multidisciplinary teams that didn't just have people such as myself as the clinician, but also bioinformaticians, clinical geneticists, and bespoke software so we could consider every variant we saw. We used the standards of the American College of Medical Genetics to decide if variants were pathogenic or likely pathogenic, and they were the only ones to be fed back to clinicians. And what we found was 1 in 5 of our cases with this phenotype had likely or pathogenic mutations in these 2 genes. Now you may say, does this matter? I see my women in pregnancy, most of them get better subsequently. Do they need to have genetic testing? And I'll try to tell you why I think this is important. Children born with 2 pathological mutations in these biliary transporter genes have severe childhood cholestasis. They often require transplant of the liver in infancy. They're at risk of hepatobiliary malignancies and can be very sick. Typically mothers with ICP or people who have transient drug-induced cholestasis and other forms of transient cholestasis have 1 pathogenic mutation. So they're normally heterozygotes, but we and others have followed the pedigrees of these people. And as I mentioned in the study earlier, we're finding that women and their relatives have about a 3 to 5-fold increased risk of gallstone pancreatitis, which is potentially life-threatening, cirrhosis. 10% of our women, as I mentioned, seem to have cirrhosis, as do their relatives. And the older relatives, we're finding a number with cholangiocarcinoma. So I think there is an argument that these women should be referred for genetic screening. And now in the UK, this has been adopted by the NHS Genomic Medicine Service for women with more severe early onset disease, because then we can refer them to hepatologists and they can be treated with drugs. The simple one is ursodeoxycholic acid, but there are more drugs coming on the market now that are likely to protect these women for decades and keep them healthy as they become older. And of course, this is of relevance to their other relatives who have not been pregnant, who may be found to also have the same mutations. So I want to come on now to consider itch in cholestasis. As we all know, most of us identify the women that we diagnose because they present with pruritus. And I show here a slide of a woman's back with the typical changes. So they don't have a dermatosis of pregnancy. You often see scratch marks and these lesions on the skin secondary to chronic scratching. Often people will say to me, I have a woman whose bile acids are very high, but she barely has any itch, or a woman who has bile acids that are barely raised, but has terrible itch. And I think it's a consistent experience that bile acid concentrations do not correlate well with itch scores. But there have been studies that have demonstrated 2 pruritogens that are elevated in cholestasis of pregnancy that are likely of relevance. And I think it's worth knowing about them because we should think about interventions and drugs that can reduce the levels of these. So I'll tell you about the research supporting both of them. Firstly, lysophosphatidic acid. It's a phospholipid which causes itching in mice. It's associated with itching in cholestasis outside pregnancy. And the work on pregnancy was done very nicely by a team from Amsterdam, Andy Kramer, Ronald Udelfrink. And they showed this on the left graph. These are samples from normal pregnant women. These are samples from pregnant women with cholestasis, an increase in lysophosphatidic acid. Now, this phospholipid is synthesized by autotaxin, an enzyme, which is quite stable in blood samples. And they were able to show that compared to non-pregnant controls, that is the HC in the middle graph, pregnant controls without cholestasis had some elevation, maybe explaining some of the itch in normal pregnancy. And then women with ICP had further elevations, shown in the middle graph and in the Western blots on the right. Now, whilst they were studying this, our own group studied progesterone metabolites. Whilst it's known that progesterone levels themselves are the same in cholestasis of pregnancy as uncomplicated pregnancy, the concentrations of the sulfated metabolites goes up. They go up in normal pregnancy about 100-fold compared to non-pregnant individuals, and up again 3 to 4 times in cholestatic pregnancy. So in collaboration with the group in Amsterdam, we did a study of both autotaxin and progesterone sulfates in women with previous ICP or previous uncomplicated pregnancy. So we could have early pregnancy samples and follow them through pregnancy. And essentially we found that both autotaxin and progesterone sulfates are associated with increased itch scores. And as progesterone sulfates double, the itch scores go up. We went on to try to understand how do they cause itch. And because progesterone has a very similar structure to bile acids with the steroid nucleus, and these progesterone sulfates are quite similar, we studied one of the bile acid receptors. And what we found in cells that were transfected with this receptor, when we added to the culture medium the progesterone sulfates at the concentration seen in normal and cholestatic pregnancy, there was an increased release of cyclic AMP, indicating that they were activating this bile acid receptor. We went on to inject the compound into mice and caused an increased number of scratches, represented by the graph here and the higher bars. But when the mice were deficient of the bile acid receptor, this went down markedly. So we suspect that both autotaxin and progesterone sulfates play a role in itch in cholestatic pregnancy, and hope that the drugs we'll try over the next few years will reduce these compounds as well as improving cholestasis. Now, it's worth also knowing that women with ICP have increased rates of gestational diabetes as well as increased rates of preeclampsia. There have been some very nice big population studies, and I think some of the first and very convincing ones came from the Swedes, including this one. And if you look at gestational diabetes, here they show an increased rate of gestational diabetes in women with cholestasis, with an odds ratio just under 3. Now, while they were doing this lovely work, we were doing more experimental medicine studies. And Marcus Martineau, when he was a PhD student with me, did continuous glucose monitoring in women with ICP and showed that the postprandial blood glucose concentrations were consistently raised, not so much the fasting samples. He had similar results from glucose tolerance tests shown on the left. And then he also studied lipid profiles. And this is consistent with other studies, was able to show that there are increased triglycerides and total cholesterol, represented really by the LDL cholesterol fraction, in women with cholestasis compared to uncomplicated pregnancy. And I think these data are of relevance when we're considering adverse outcomes. Do bear in mind that your woman may have cholestasis plus another metabolic disorder that might also make her fetus at risk. So for the next part of the talk, I would like to consider the ICP-associated adverse pregnancy outcomes, what we know about them, maybe how we can try to predict them, and can they be prevented? So firstly, thinking about biochemical markers that can help us identify pregnancies at risk of adverse outcomes. And again, I would say the most impressive cohort study that was done first was from the Swedish group. They studied just under 700 women with itch in pregnancy, and they measured bile acids and liver transaminases and bilirubin in all. They studied the rate of fetal complications in the women, and they found that they did not increase until the maternal bile acid concentration was above 40 micromoles per litre. And then they found as the maternal bile acid concentration increased, so did the rate of adverse outcomes. Now, this study had just under 100 women with bile acids above 40, but they subdivided them into a different group, those represented by the dark bars, to those with a mild increase in bile acids from 10 to 39, or no increase in bile acids, represented by the white bars. And you can see in the graph below, each of these adverse outcomes, spontaneous preterm birth, meconium-stained amniotic fluid, and so on, were higher in the group with bile acids over 40. They were not powered to study stillbirth because they had about 96 women with bile acids over 40. So we applied to do a UK national cohort study that was supported by UCOS. We were able to address this in slightly under 700 singleton cases with maternal serum bile acids over 40. And in this study, we confirmed what Anna Glantz and Hans-Ulrich Marschall showed, that there is a significant increase in the risk of all preterm and spontaneous preterm birth. We also had sufficient cases to show a significant increase in the likelihood of stillbirth in women with bile acids over 40, but we still didn't know if there was a specific threshold for different complications. Did we really have to worry about stillbirth in those with bile acids over 40? So we went on to do more work, and thank you of anybody who provided us with samples as listening to this talk. It was an international study. We studied just over 4,000 women doing an individual patient data meta-analysis. And in this study, we included data from any randomized controlled trial or any cohort study that had at least 30 cases with data on serum bile acid concentration and pregnancy outcome. And as much as possible, we also included data on the other liver tests. But I think the most important first results we had was that total serum bile acids are more predictive of stillbirth for singleton pregnancy than any of the other biomarkers. And truly, there was very little association for the others. This is represented on a receiver operator curve here, which I think illustrates the point nicely. The red line represents total serum bile acid concentrations, and it represents the maximal concentration at any time in the pregnancy. That has a relatively high area under the receiver operator curve, 0.8, representing a good predictive biomarker. Whilst ALT, the liver transaminase, is almost on the diagonal line with an area under the curve just under 0.5, indicating that this is not a good predictive biomarker. So we went on to study the serum bile acid concentration in more detail. And I'll just explain these graphs to you. On the left, the bar graph on the x-axis represents maternal total serum bile acid concentrations. And again, this is the maximal concentration at any time in the pregnancy. And we represent them in increments of 20, 0 to 19, 20 to 39, and so on. The blue bars represent total number of cases in the study at each concentration. And you can see there are thousands of women at the lower extents of elevation of maternal serum bile acid concentrations. As we get to 100, 120, 140, there are hundreds of women, but not so many, and this is about 10% of the cohort. However, if you look at the red bars that represent stillbirth rate, the numbers increase quite markedly once maternal serum bile acid concentrations go above 100. In the right-hand graph, we went on to plot the stillbirth rate according to the number of fetuses still in utero at different gestational weeks. And we subdivided the groups into those with bile acids under 40 micromoles per litre, represented by the green line, from 40 to 99, represented by the purple line, and 100 and above, represented by the red line. And you can see the group with the significantly increased stillbirth rate is this group with serum bile acid concentrations above 100. And if you look at the gestational weeks, this seems to go up somewhere between 35 and 36 weeks of gestation. We plotted a very similar set of graphs for preterm birth, and I'll briefly talk you through these. On the left-hand side again, on the x-axis, you can see maternal serum bile acid concentrations in increments of 20. The blue bars represent number of cases again, very similar. The red bars represent all preterm births, and you can see these gradually go up as maternal serum bile acid concentrations increase. But we also separated spontaneous preterm birth and iatrogenic or medically indicated preterm birth, represented by purple. And you can see for the green bars, which is the spontaneous preterm birth, again, the rates go up as maternal serum bile acids become higher. And in the right-hand graph, we did the same as for the stillbirth data. We plotted the spontaneous preterm birth rate according to the proportion of fetuses still in utero. And you can see that here there is a significant increase when we compare those with bile acids under 40 to those with bile acids from 40 to 99. It's not a major increase. There is a much more marked increase when the maternal serum bile acids are above 100. So what can we take home as evidence-based recommendations from these data? Firstly, 90% of your women with serum bile acid concentrations under 100 micromoles per litre can be reassured that they do not have a significantly increased risk of stillbirth. Those with serum bile acid concentrations under 40 can be reassured they do not have an increased risk of spontaneous preterm birth or stillbirth. But I would recommend checking serum bile acid concentrations regularly, ideally weekly, because they tend to go up with advancing gestation. And I fully appreciate that not all hospitals can do bile acid measurement, and we may want to speak about this later. But if they're available, I would recommend this. And I'm delighted that this is starting to appear in the guidelines. I hope that when the RCOG guideline comes out, likely later this year, it will also be represented there, as I hope it will be in the European guideline, which will come out soon after that. Another question that people often ask is, should I measure serum bile acid concentrations when a woman is fasting or after she has eaten? And I hope this experimental medicine study goes some way towards giving some answers for this. These are women that were given a standardized meal the night before they were studied. They came to the hospital fasting in the morning, were giving a standardized breakfast and a standardized lunch. And all the meals had sufficient lipid in them to ensure gallbladder emptying. The groups are divided into those represented in blue that had severe ICP, which is defined as those with serum bile acid concentrations of 40 or above. Those represented in red had milder ICP, so they had elevated serum bile acid concentrations above the normal range for their laboratory, but below 40. And those represented by the white circles had uncomplicated pregnancy. So one of the messages from this paper is, if only fasting bile acid concentrations are measured, the majority of women who will constitute the high-risk group will not be identified, while if postprandial bile acid concentrations are measured, they will be ascertained. And I hope this is a useful piece of information for clinicians, and maybe also makes women's lives a bit more pleasant because they don't have to fast a lot when they come in for bile acid measurement. Another important message is there is a lot of overlap between women with milder ICP and controls. And from this, in this paper, we did recommend that the normal range, upper end of the normal range, is increased. We also did show a slight difference in the normal range between women of white European origin, Asian origin, and Black women from London. And those of South Asian origin and Black women had slightly higher normal ranges, but if the normal range were moved to around about 19 or 20, that would probably allow a lot more accurate diagnosis. So I now want to come on to consider treatment. And most of you will know about the PICTURES trial. This was led by Lucy Chappell. I was a co-investigator, as was Jim Thornton. And this was delivered in the UK across many units. It is the largest trial that has been done to date. And it aimed to determine whether ursodeoxycholic acid treatment compared to placebo, when used to treat women with ICP between 20 to 40 plus 6 weeks of gestation, reduces a composite of adverse outcomes that includes in utero fetal death, no neonatal death up to 7 days, preterm birth, and neonatal unit admission for at least 4 hours. When you look at the women at baseline, they were very well matched. There were just over 600 women in the trial. They were also well matched for itch scores and biochemistry. But I include the red box here just to bring your attention to the fact that only 24% of the cases had serum bile acid concentrations above 40 at the time of randomization. So the results of the PICTURES trial were that ursodeoxycholic acid compared to placebo did not reduce the rates of the composite adverse outcomes. Although you will see that 1 or 2 of the results showed a trend towards suggesting that possibly ursodeoxycholic acid is of benefit. In terms of secondary outcomes, there was a significant reduction in meconium-stained amniotic fluid. There was also a significant reduction in itch score, but the mean difference was a reduction of 5.7 millimeters on an itch analog score of 100 millimeters. So according to a pre-specified indication of what pregnant women and clinicians thought would be clinically meaningful, this did not reach that, which was 30 millimeters. But there is some reduction in pruritus. There is a significant reduction in transaminases concentrations, suggesting that maybe ursodeoxycholic acid is hepatoprotective to a degree. And it was intriguing that there was no reduction in serum bile acid concentrations. But I will try to explain this to you. This is because the total serum bile acid assay measures ursodeoxycholic acid as well as the bile acids that are normally raised in cholestasis of pregnancy. And maybe the simplest message is to say not all bile acids are equal. Ursodeoxycholic acid is a hydrophilic bile acid that is protective towards most cells, while the main bile acids that are raised in cholestasis of pregnancy when untreated are more hydrophobic and harmful bile acids to cells. There was a study that came out very soon after the Pictures trial that explained the differences. So if you look here at CA and CDCA, the names don't matter, but these are the primary bile acids and the main ones that are raised in cholestasis in untreated women. So you can see here 51%, 25% bile acids in the whole bile acid measurement of the blood. When women are started on ursodeoxycholic acid, the proportion of these harmful bile acids reduces. Whilst in contrast, ursodeoxycholic acid is barely present in untreated women, but becomes about 60% or say 50 to 70% of bile acids in treated women. So although the Pictures trial showed no reduction in total bile acids, it can be assumed that there will have been a reduction in the harmful bile acids and an enrichment with ursodeoxycholic acid. The other paper that came out a few weeks ago that it is worth knowing about is a subsequent individual patient data meta-analysis that our group performed. We were interested to know particularly, is there a difference in response in those with bile acids above or below 40? But also we wanted to study singleton pregnancies because outcomes are different between singleton and multiple pregnancy, and also consider individual adverse outcomes. And with just under 7,000 participants, we did show that ursodeoxycholic acid treatment does reduce the rate of spontaneous preterm birth in singleton ICP pregnancies. But if you look at the graphs, there was really no change in women with bile acids under 40, but there was a significant reduction in those with bile acids greater than 40. And also when we did a number needed to treat analysis, we cannot and were not powered to study stillbirth in isolation. But when stillbirth and preterm birth were combined, the number needed to treat was 14 to prevent one event. So I think the data here show ursodeoxycholic acid is not a perfect drug. It has a minimal impact on itch, and it may not have a major impact on serum bile acid concentrations in all women. However, in women with bile acids greater than 40, it is likely to protect against spontaneous preterm birth. And I think I've just spoken ahead of myself, and essentially this is also summarized in this slide. But it's useful to consider, could we use other treatments? And there are 2 trials starting that will maybe give us data on additional treatments. One is rifampicin. We all know that there are basically good safety data for rifampicin in pregnancy because it's used to treat some infections such as TB. We have to be aware of the idiosyncratic drug reaction that can cause raised transaminases, but in my own experience, when you stop the drug, that goes back to baseline. We published a small retrospective study. It was an international collaboration of women who did not respond to ursodeoxycholic acid, but a subgroup, about a third, did respond to combined ursodeoxycholic acid and rifampicin. Following from this, Bill Haig in Adelaide is now the chief investigator of the Terrific trial. This is a trial that will compare ursodeoxycholic acid and rifampicin for its effectiveness for pruritus, which is important because we know that rifampicin is effective for pruritus outside pregnancy in people with cholestatic itch, but also with secondary adverse pregnancy outcomes to be studied. So I very much look forward to the results of Bill Haig's trial. I'm also chief investigator of a study of allyl bile acid transport inhibitors, which is a drug that has been shown to be effective for children with genetic cholestasis and for some other forms of cholestasis. It's a drug that is not systemically absorbed, but stops the gut from reabsorbing bile acids in the enterohepatic circulation. We're going to start with a safety and efficacy study, and if we can confirm this, move on. But I hope this may also be a trial of a new drug that hopefully will be very effective in this disorder if the results in pregnant women are as encouraging as they are in non-pregnant individuals. So for the final part of the talk, I would like to talk to you about what else we know about mechanisms causing adverse outcomes for the baby and possibly for the mother. This slide is to really illustrate the point that we have to remember the fetus can make bile acids from early in gestation. But typically when the mother's bile acids are normal, they are transported across the placenta because the fetus does not have an enterohepatic circulation to excrete bile acids via the feces, and there's maternal excretion. But in cholestasis, when the mother's bile acids become very high, the gradient goes in the opposite direction and fetal bile acids are also raised. And I think this is important because our measurement of maternal bile acids is probably a surrogate to tell us what is happening in the fetal compartment that is causing the fetus to be at risk. And a few years ago, we hypothesized that maybe the cause for the fetal risk could be cardiac, because ICP fetuses are normally grown and there's a sudden death, sometimes after normal CTGs or assessment of the fetus on the same day. We developed an in vitro model of neonatal heart cells, cardiomyocytes, and we grew them to confluence, loaded them with a calcium indicator, and you can see they all beat synchronously. So we were interested to just see what would happen if we add bile acids to this. We add bile acids to the culture medium at the concentrations we see in cholestasis. Oh, I'm sorry. And we saw a loss of synchronous beating. But when we added ursodeoxycholic acid to the culture medium, they were protected and synchronous contraction remained. So we've gone on to do a number of studies with our collaborators at Imperial on this. And over the last few years, we've done some human studies where women very kindly wore a fetal ECG monitor overnight. We adjusted for fetal sleep state, heart rate changes with sleep and maternal position. And we found that women with cholestasis have significant increases in fetal PR interval length, abnormal heart rate variability, and in the umbilical venous blood, there was an increase in NT-proBNP, a marker of ventricular dysfunction and strain. We also found that those treated with ursodeoxycholic acid, the latter two were ameliorated. So maybe some other evidence for ways that ursodeoxycholic acid may be protective in some cases. I'd like to bring you back almost full circle to what I said related to the genetic studies. The Swedish group have published very beautiful studies showing the increased risk subsequent to pregnancy of hepatobiliary disease in women with cholestasis. Hepatitis C, I suspect women have it before they're pregnant, and something in pregnancy unmasks the susceptibility to becoming cholestatic associated with the virus. Chronic hepatitis could also capture those with autoimmune disorders, but fibrosis, cirrhosis, gallstone disease, and so on, I think probably relates to genetic susceptibility. Absolutely consistent with the work from a number of groups, including the French groups referenced below, who've done work on the effect on first-degree relatives as well as women with cholestasis. This is the study from the Swedish group that also shows the increased rates of liver and biliary tree cancer. It's a rare cancer, but considerably increased in women with cholestasis, and I hope lifetime treatment with drugs such as ursodeoxycholic acid may protect them. And finally, as with many other conditions, there is also, I think, a story for children. And this study of the Northern Finland birth cohort showed that 16-year-old children of women with cholestasis have increased adiposity. The boys had double the fasting insulin, and here are the girls again with increased adiposity and mild but an existing dyslipidemia. We don't know what the impact of treatments may be for this, and there's some emerging data to suggest that maybe if the mother is treated with a drug such as ursodeoxycholic acid, this may be less likely. So I'm going to stop there. This is the talk in one slide. I'm very happy to take questions, and I'm looking looking forward to discussing the cases. This is my research group. Those indicated in red primarily contributed to the work here. The people at the bottom are collaborators. On the right. Thank you very much for listening to me.
Thank you very much, Dr. Catherine. I think in a short time you have covered so many things with so much evidence that I'm really impressed. Starting from the genetic predisposition to the effect on having preeclampsia, diabetes, and the future, that if somebody has IHCP, we have to probably have a look out that in future what can happen to them. They may have more cancer or cirrhosis or chronic hepatitis. I had once done a study. Do you have any experience that, like, we don't have, at most places, access to bile acids, which is the best marker? So we keep trying to find alternatives. So once we did a study in which we did mean platelet volume and D-dimers, and we found that mean platelet volume more than 30 was independently associated with poorer fetal outcome, taking the hypothesis that the bile acids affect the chorionic villi vessels, cause vasoconstriction, and there is a DIC-like picture with increase in the coagulation, increase in the fibrolysis, and which will lead to increase in the platelet volume. So do you have any experience or any something, you heard something like this? We did found good relations, and 110 patients we did.
It's a very interesting study. I absolutely agree. Bile acids can cause vasoconstriction, and this could be an explanation of the association. We have done some work on vasoconstriction, but they're difficult experiments to do. We used a placental perfusion apparatus following on from some of the studies from Chile that did this in the past. And we did find that bile acids are vasoconstrictive, and we did find that some are more vasoconstrictive than others, and it's the more hydrophobic, potentially harmful ones that are. But in our own hands, I don't know if any of you have done these experiments. You have a lot of loss of placentas because you have to get very tight connections, and it's difficult the way you dissect it out. We didn't have quite enough to have significant numbers to publish, but I absolutely agree with you. Our data were consistent with the published data, and bile acids are vasoconstrictive. So that could explain that. And I think whilst you don't have bile acids, any surrogates you have are worth using. So this is a very intelligent, sensible approach. It would be lovely if over the next months and years, it were possible to find a way to have bile acid measurement. And as we have briefly discussed before, maybe we can discuss this offline subsequently. But I think it's a very nice thing to do.
Thank you very much, Dr. Catherine. And it's a privilege for us to have listened to you with so much material you have given us. Thank you. Over to you, Ranjana. Hi, Shelly.
Shelly, unmute yourself. Sorry. Ma'am, it was such a nice talk. After such a comprehensive, immaculate talk, let's move to our next session of case-based discussion with our own expert, Professor Catherine Williamson, for which I would like to invite our dynamic moderator, Dr. Jyoti Bhaskar. Dr. Jyoti Bhaskar, she is a President DGF East, Senior Consultant Obs and Gynae, Apollo Cradle Indrapuram, and Dr. Sangeeta Gupta, she is Secretary NARCHI, Director Professor Obs and Gynae, Maulana Azad Medical College. Along with them, I would also like to invite our esteemed group of discussants, Dr. Sohani Verma. She is a Senior Consultant and IVF Specialist at Indraprasth Apollo Hospital. She is our past Chairperson RCOG North Zone 2012 to 2017. Dr. Manju Puri, she is a Chairperson Safe Motherhood Committee AOGD. She is a Director Professor and Head Obs and Gynae of Lady Hardinge Medical College. Dr. Asmita Rathore, she is President NARCHI, Director Professor and Head Obs and Gynae, Maulana Azad Medical College. Dr. Uma Ram, she is Chairperson South Zone AICC RCOG, Director and Consultant Obs and Gynae, Sitapati Clinic and Hospital in Chennai. Dr. Manju Khimani, she is a Chairperson of Endometriosis Committee of AOGD. She is Director Obs and Gynae at Max Mart Super Specialty Hospital. Dr. Josna Suri, she is a President AOGD, Professor Obs and Gynae at Safdarjung Hospital. Over to you, Dr. Manju. Over to you, Dr. Jyoti.
Thank you so much, Shelly. So me and Dr. Sangeeta, my co-moderator, we're extremely honored to have Professor Catherine as our expert and a faculty of very senior, esteemed, our own faculty from Delhi. So after this lecture, I think it's been made very easy for both of us to really carry over this case-based discussion. But still, we would like to redo it again. And the main aim of this particular discussion that we are going to have through the 6 cases that we're going to do is to establish the diagnostic criteria to determine severity and the adverse outcomes, to actually decide what is the right time to deliver our patients so that we get the best outcomes. More importantly, to remove the fear that we obstetricians have of stillbirth in IHCP, and thus to decrease the iatrogenic preterm delivery rate, and somewhere to address the guilt that we do have, that are we somewhere responsible for increasing the incidence of IHCP, especially in India. With these particular aims, without wasting time, I'm going to go on to my first case. She's a gravid 2 para 1, 34 weeks pregnancy. She's diagnosed case of IHCP. She's already on UDCA, 1,200 milligrams per day. She's been very well monitored with the ALT, AST, and bile acids. Symptomatically, itching has become much better. We did an ultrasound. The baby seems to be perfectly fine. No IUGR, like a normal, Doppler normal. If you look at her reports, when we did at 32 weeks, ALT, AST was 300, 260, and it's were 20. We increased at this time the UDCA to 1,200 milligrams. We repeated it at 34 weeks and we got it to be 150/90. That is, yes, the transaminases has come down, but surprising, the bile acids actually remained or became much higher, that is 260. So Professor Catherine, I would like you to address 2 aspects of this. First of all, is there a correlation between the transaminases and the bile acids in the diagnosis of IHCP? Or are they 2 separate things? And we get very happy when the ALT/AST comes down if you are not doing bile acids. And second thing, which you do have addressed in your particular talk, but I would like you to re-underline, does UDCA actually have any role to reduce the transaminases and bile acids, and thus to tell us, yes, the disease is becoming better, because we know it is an off-label drug, and 6 national guidelines, I think all over using UDCA as a first line of treatment. So Professor Catherine, to you.
Thank you. So to start with your first question, well, I could address the question and also what you just said. So in terms of the ALT, AST coming down and the bile acids going up, this is not uncommon at all. I think there is no doubt pictures illustrated it for a milder, on the whole, milder cases than are shown here. But ursodeoxycholic acid tends to be hepatoprotective. So in terms of thinking about maternal disease, it probably does protect the liver a bit. And this is no bad thing because it replaces the bile acid pool with non-harmful bile acids. The disease process, I think, is continuing, because the disease process is likely caused by a combination of genetic susceptibility or possibly underlying disease susceptibility, and then the reproductive hormones in pregnancy being cholestatic. And until the baby is delivered, that will not go away. So the question is, can the drug contain the cholestasis? So it certainly protects the liver. In this case, probably 60% of the 60 bile acids you see are ursodeoxycholic acid. So it may be that the bile acid concentration of the more harmful bile acids hasn't changed so much, but the disease process is continuing likely, and your increase of dose of ursodeoxycholic acid may have helped. So again, as I said in the lecture, I think ursodeoxycholic acid probably has a place, particularly for those with higher bile acids, but it is not, sadly, the perfect drug. We still need to find the perfect drug or other drugs to use in combination. So in terms of role of urso in management of ICP, are we convinced it reduces the adverse outcomes? I think for a woman with bile acids over 40, I would want to use it now, having done the IPD meta-analysis. I think there could be a debate about whether it should be used in those with lower bile acids. and in those at later gestational weeks. Once you're past 37, 38 weeks, maybe there isn't a place for it. So we should probably individualize our management. But I am reasonably convinced that it has some impact on adverse outcomes from the data we have from the IPD meta-analysis now. And of course, this relates to singleton pregnancy, not multi-fetal pregnancy. And this is something we were able to do with individual patient data, was study singleton and study spontaneous and not all preterm birth together.
Thank you so much, Professor. So,
Jyoti, can I ask one question here from Dr. Catherine?
Yes.
Dr. Catherine, that was a wonderful lecture. So question which is coming to my mind is that, we are managing our patient, their termination according to bile acid. So once we have done enzymes and bile acid and we have confirmed it is IHCP, what is the need of doing, liver enzymes when we are going to manage her with the bile acid only? Do you agree with me or no?
It's a very good question. The way I think about it is we're thinking about the maternal disease and the pregnancy outcome separately almost. So for transaminases, to be fair, I'm not sure that your liver transaminases help you with your decision for delivery, because that really is a decision that is much more based on bile acids. But there is the occasional woman whose transaminases become worse and worse. They're rare, but they occur. So your advantage of having transaminases sometimes is really thinking about the mother. And the occasional case, you probably have them, where she has another disorder, but it's presenting as cholestasis. I've seen women with acute fatty liver of pregnancy where they're first thought to have cholestasis, and then the acute fatty liver takes over. And the same can occur with some hepatitis. So it's really thinking more broadly as physicians of the mother. And for the majority, they will not influence what you do at all. But there's the occasional case where you pick her up earlier. But otherwise, I think it is the bile acids that are needed to make the decision. And another question people often ask, once I have a bile acid over 100, do I need to check them again? And in fairness, maybe you don't. And particularly if it's an expensive assay, you have an answer you need to make your decision.
Thank you so much, Professor. So Dr. Manjipuri, I would like to get you onto over here, because as we were discussing at that time, you being in the government hospital and bile acids being expensive, and we do not have the facility of doing bile acids. So what would you consider in your particular settings about managing these patients only with the transaminases? And would you like to take this discussion forward with Professor Catherine?
Yeah, I think, Jyoti, this is something which is very, very important for us. And we face it day in, day night. So, Catherine, I would want to know as to, supposing we do not have bile acids available, then do you think a combination of the clinical picture and the transaminases would help us in some way in making the diagnosis? We understand that the diagnosis is made by clinical picture and raised bile acids. But still, what would you say about that?
Yeah, I think you have a very difficult situation, and I think you have to do your best. What is used in some studies is bilirubin, and the association with adverse outcome, if you look at the Avadia paper 2019, there is more association with bilirubin than there is with ALTs. So maybe you want to look at a combination. And if you have any surrogates, so if maybe with a larger number of cases, you could go back and see if the platelet volume, for example, is helpful. But I would certainly think about bilirubin as well as transaminases. It's very difficult. They do not have a good association. They're not as good as bile acids, but you have to do your best. There are other considerations. I always ask every woman I see if she's noticed a change in the color of her feces, because those are the women at risk of fat-soluble vitamin malabsorption and maybe at risk of bleeding at the time of delivery. So at least you can stratify your women a bit more on clinical grounds as well. And those women can be given vitamin K and ideally water-soluble vitamin K to protect them. It's tricky. Severity of itch doesn't really correlate with severity of bile acids. However, if a woman is finding her itch absolutely unbearable and psychologically distressing, that probably would influence your decisions. So I think I'm sure being in that situation, you're functioning as very good clinicians, taking a good history and so on, and you have to do your best. But I am very, very keen to speak to you all about ways maybe we can help in trying to ensure you can obtain the assays a bit more cheaply. The measurement itself should not be so expensive. You need to find a company, a machine, and a lab that are maybe happy to take the risk to start doing it. I think an economic analysis would show you probably save money by doing it, because 90% of women don't have to be delivered early.
Right. Thank you so much, Catherine. So maybe I can take it further. So in your paper, which you have recently published in British Journal of Obs and Gynae, in which, we see you've talked about postprandial. You had showed us that graph in your talk also. So what is your take on, what should we depend upon? Should it be fasting? Should it be, postprandial? Should it be something like GTT, like a, challenge we give to the patient and then take it? And so what is your take on that?
I think it's a brilliant question, and your thoughts reflect my thoughts. I think there are a lot of parallels between gestational diabetes and gestational cholestasis. And in a sense, but for gestational diabetes, of course, it's important. And when you're stratifying women, you need to know about fasting and postprandial glucose. For cholestasis, for pregnancy management, I think postprandial is what we need. So again, that would save money. A single postprandial measurement at some point through the day. They seem to be highest mid-afternoon, but in all reality, they look pretty similar in all postprandial measurements. So a single measurement of non-fasting bile acids is probably most valuable. There could be an argument if you're trying to minimize cost. A single measurement at 34 weeks of a postprandial bile acid might be the most useful time to do it. But I think your point, your question is very interesting. Many of my hepatology colleagues would say to me, we have to make this diagnosis fasting because this is what is done in non-pregnant individuals. It's very well recognized in non-pregnant individuals that feeding causes a rise in bile acids, not surprisingly when we understand the physiology and the gallbladder contraction, but it's different for pregnancy. We're thinking about pregnancy outcomes, so I think we need to know the peak.
So thank you so much, Professor Catherine, as well as Dr. Manjupuri. So the main thing that we have achieved from this particular case is this, that bile acids should be postprandial and we should not go in for a fasting. If you have money crunch, then only one sample at 34 weeks. UDCA definitely is the first line of treatment we should start in these particular patients. Bile acids is the most specific marker that we should try and use it. But if we do not have that, yes, then we need to use a clinic as well as a transaminases as a method. With this, we go on to the next case and I hand it over to Dr. Sangeeta. Dr. Sangeeta?
Ma'am, you are on mute.
Yeah. Am I audible now?
You're audible, yes.
Yeah. So with this vibrant discussion about the first case, now we move on to the case 2. And Dr. Jyotsna Suri will be coordinating the discussion here. It's a 30 years primey, 32 weeks of pregnancy, who had come to us with pruritus for about a week on her palms and soles, and there was no associated rash. Although there was no complaint of pale stools or dark colored urine. We got her LFTs and bile acids done. Dr. Jyoti, will you please get the next slide? Yeah. And this was her profile. And we can see the bile acids are as high as 134. And of course, this becomes a befitting diagnosis of intrahepatic cholestasis of pregnancy. So my first question to you, Dr. Catherine, here is, would you consider delivery here at 32 weeks in this woman?
Very unlikely. You can never have absolute rules, but she's primogravid, she's 32 weeks, and you will remember the graph that shows the real increase in stillbirth rate seems to occur somewhere between 35 and 36 weeks. So given the recent IPD data now, I would be tempted to give this woman ursodeoxycholic acid, watch her very closely, advise her about informing us if there are any change in movements and so on. But I would not, unless there were another reason to consider delivery, I would not consider delivery yet.
Thank you so much. Next slide, please. So the pregnancy was carried on further. And you can see the trend. She came to us, she was started on ursodeoxycholic acid, and we had combined chlorpheniramine to relieve her itching. And she had followed up the next week where her bile acids showed a trend, decreasing trend, and so did her transaminases. And at 35 weeks, 34 weeks, even vitamin K was added to this. And so my next question to you is, if LFTs and bile acids are on a receding trend, when do you deliver her? Should we deliver her at 36 weeks, or can we carry her further to 37 and 39, just monitoring her bile acids and then tailoring between 37 to 39? I think you had answered that question in your talk, but I think it will still be nice if we can have another reiteration here.
Yes, I usually recommend for these women delivery between 35 and 36 weeks. And obviously we individualize every case. We talk it through with our neonatology colleagues, the woman, her partner, and so on. But I am concerned that when every way we try to analyze the data, the risk of stillbirth seems to relate to the maximal concentration of bile acids in the pregnancy. And so it's very difficult with these cases because there are some people who do respond to drugs such as ursodeoxycholic acid, or are maybe getting better anyway if she'd had a precipitant to cause her cholestasis to become bad. There are some women who've been given an antibiotic for a UTI or have had an intercurrent viral infection who seem to have an exacerbation and then improve a bit, and she could be one of those. But I would usually still recommend delivery between 35 and 36 weeks for most women. I'd love to be able to do the trial that gives us an answer as to whether we do need to do this. But one of the reasons I'm not totally relaxed if the bile acids come back to normal is there was a study in the past, I think by one of the Portuguese groups, that reported the umbilical venous bile acid concentrations in UDCA treated women and the meconium concentrations. And the umbilical venous concentrations come down, but the meconium concentrations remain high, even if the umbilical venous concentrations come down. And I always worry that there could be a concentration of bile acids in the meconium, because although the fetus doesn't have a proper intrahepatic circulation, they seem to concentrate. So there could be an area under the curve of exposure. And then if that fetus passes meconium, there could be very high concentrations of bile acids. So as long as we don't know, my instinct is to just follow the data and recommend delivery.
Thank you so much for that answer. So Dr. Catherine, what's your take on role of antenatal steroids in these women?
This is a cause of much debate. My view, I should tell you, as you probably know, I am an obstetric physician and not an obstetrician. So I work very closely with my obstetric colleagues, and I would usually say I think they should follow their own guidance for antenatal steroids. I don't think there is a different requirement for antenatal steroids. So they should be used as they would be used in any other pregnancy.
So Dr. Jyotsna, would you like to tell us what should we be doing in this patient in whom we have not given any antenatal steroids so far?
Yeah, thank you, Dr. Sangeeta, and a very good afternoon or good evening, Dr. Catherine. So I think this case is a really challenging case. And at 32 weeks, when she has come with such high bile acids, I totally agree with you that, you know, one level we have and we don't have the, you know, the resources to keep doing it. So that was a very value added, you know, point you made, that just one value is enough. And now you know that you have to terminate this pregnancy. Now, the point is that, as you said very rightly, that 32 weeks is too soon. But I think, again, we would individualize. Suppose it was a case with a, you know, she 32 years old. If she was in India, the marriages are early and we don't know really what is her obstetric history. Was it a precious pregnancy? Or if she is a multi, did she have a previous stillbirth? So, you know, those kind of issues have to be considered before we actually, you know, take the decision that we carry on. You know, we are really sitting on a kind of a time bomb. And then if we don't have the facilities, especially to repeat bile acids weekly, so then also, I mean, what would you do, Dr. Catherine, in such situation where we are treating our patients like this?
I think your points are very well made. And when I said, as she is prima gravid, I was thinking the same way as you. If she's had previous adverse outcomes, that totally changes the way you think. And so of course we individualize cases. And I've had women who've had stillbirths at 33, 34 weeks. That is very different to those who haven't. And another thought on antenatal steroids, sometimes women with severe disease at 30, 31, 32 weeks, we do discuss the option of giving antenatal steroids at that stage because she's at increased risk of going into spontaneous preterm birth. So that is different maybe to thinking, should we give them at 35 or 36 weeks? Well, most of my colleagues would say we would not because it doesn't adhere with our guidelines. So I absolutely agree. We have to individualize our decisions around all women. It's very, very important. And these severe cases are rare. The mild cases are common, and for them, I think we want to reassure them at times, particularly if we can show their bile acids aren't so high. But with a case like this, it's very, very important to have team decisions.
Yes. So I think we would also have given steroids at 32 weeks in the way setup where we were, keeping that option open that we may need to deliver her, and also that she may go into a spontaneous preterm birth. And about when to do the prothrombin time, is it in all cases or in cases that which are symptomatic with steatorrhea? So that is also an issue. What would be your take on that?
I think it's a very well crafted question, because the way I think about this, I ask everyone if they have steatorrhea, and if they do, I would want to check their coagulation, and I would give them vitamin K. The other group I worry about are the women with more severe disease, such as this one. If her bile acids are over 100, I usually want to check their coagulation as well. And I do push them on steatorrhea. Again, as we're all clinicians, we ask a few more questions. Occasionally, I would give vitamin K, and just because I'm more worried about the case and I would rather she was covered. Oh, the other group, anyone who is given rifampicin, I would give vitamin K to, and ensure that the baby is given vitamin K as well, because of the association with bleeding disorders in the neonates. So again, all cases with steatorrhea, definitely, and then the more severe cases where there is something that makes me clinically worried.
Yes, fully agree with you. I think this is the way we would also like to do it.
Dr. Jyotsna, could I just ask Dr. Catherine one more question?
Yeah, sure, please.
In this. So Dr. Catherine, if there is a sudden rise in the transaminases, is that again an indication for giving vitamin K?
That's a good question. Well, if there's a sudden rise in the transaminase, I would certainly want to check the PT or the coagulation.
Yeah.
And that could prompt me to give vitamin K. Again, I have a relatively low threshold for women I am worried about. So if her transaminases are going up, if there were any change in coagulation, obviously, but also maybe if there was quite a marked drop in the albumin in association with that, then I would start thinking maybe there's a synthetic problem. So I think it's very reasonable to think of it in those cases.
Okay. So next question, Dr. Catherine, would be that what is the formulation you prefer of vitamin K in these women?
Oh, water soluble.
Okay. The challenge in India is that we don't have an oral preparation of vitamin K available. So in that case, what would you suggest?
Gosh, you know what I would do? I'm hopeless at this. I phone my pharmacist. We have a wonderful pharmacist to advise me. So I'm not going to give you a very useful answer, except to say that as I remember, some of the capsules can be almost used as a liquid. I think I remember the pharmacist suggested something like this in the past. I don't remember the details, but I remember we had the same problem and my pharmacist was wonderful. So sorry, I can't be more helpful, but I think you'll find the right person to give you the answer.
Dr. Jyotsna?
Yeah, we are using, yes, Dr. Sangeeta, we are, as in all hospitals, we are using the menadione, this thing, bisulfite, which is available, and we are using it in the intramuscular route, 10 milligram. And most of the time near delivery, we plan to give it, because of the fear of PPH. So we are giving it around delivery time only. One more thing, Dr. Catherine, which I would like to ask you. When, it is said that if the patient is having symptoms, severe symptoms rather, and you do her bile acids, and as you also mentioned in your lecture that there may be no correlation, but it is said that don't start the UDCA, because then it could mask the increase in bile acids, which would occur later after a week or two, because the pruritus is always predating the biochemical changes. So, I have this problem. Many patients, we treat, they have such severe itching. So how to help them if we can't start the drug?
It's very difficult. I occasionally see this. I would caution you that sometimes women also have almost no itch and they have very high bile acids. So they are variable, and it probably relates to genetic background, and maybe some people are more genetically susceptible to responding to the itch stimulus. I think maybe we can't have 100% hard and fast rules. For most women, I would wait for ursodeoxycholic acid, because above all, do no harm. And even though pitches and other trials have actually shown that urso has a very good safety record, you still don't want to give drugs unnecessarily. But I've had occasional women who are desperate. I had a woman a few months ago admitted to our psychiatric hospital because she was suicidal with pruritus. So I think maybe we can't have an absolute rule for all cases, but that for women who were very, very distressed, I would document in the notes trial of ursodeoxycholic acid, because some women respond, and in this case it's necessary. But you're saying you have a lot of women like this. I don't have a lot like this. Again, one of the other questions I ask all of them is your pruritus stopping you from sleeping? Because for those cases, maybe then a 7mm reduction is worth it. So maybe we have to be a bit more flexible, but not to use it too much. Something else I do for all of my women where I'm very worried about them is I'll check their 25-hydroxyvitamin D. And this is because there was a study in mice, I think it was, where they found that mice that were cholestatic and vitamin D deficient, if they treated them with vitamin D, it upregulated the transport proteins in the kidney that eliminate bile acids. And so it's very anecdotal. I haven't done a proper study on it, but I always do it, and I give vitamin D to women who are deficient, and some of them say their symptoms get better. Now, this is totally anecdotal, but it's
thank you.
maybe an easier thing to think of.
Something we can work on for future.
So I think we're discussing this case later on also.
So I think I'll just give the outcome of this patient who was delivered at 36 weeks. We had given her antenatal steroids since she was not given any course of steroids before 34 weeks. And yes, like Dr. Jyotsna said, she was given vitamin K in the period around her delivery. And with that, we move to the next case. So this case, Dr. Asmita will be discussing.
Dr. Sangeeta, just Dr. Jyotsna, will you just tell us how much vitamin K to be given? Can you just
Yes, we give 10 milligram IM. We are giving 10 milligram, and normally we give it for 3 days.
3 days.
Yeah.
So we are moving to the next case. She's a primary gravida, 30 weeks, who has come back from Congo to deliver in India. Her GTT was done there due to a strong family history of diabetes mellitus. This was found to be deranged. She was started on diet, not controlled, and was started eventually on insulin. And the patient was not very compliant. At 32 weeks, she started having pruritus. Her LFTs and bile acids were done, and IHCP was diagnosed. And on treatment, she was started on treatment with ursodeoxycholic acid for this. At 35 weeks pregnancy, she reports to us with the aminases or transaminases of 160 and 82. Her bile acids were 52. The blood sugar control was fasting 109, postprandial 120 to 160. Not a very good control. And the ultrasound showed an estimated fetal weight on the 80th centile, and the amniotic fluid index was 20. So Dr. Catherine, we'd like to have your thoughts on when would you consider her delivery?
That's a tricky case. In the context of the bile acids, at bile acids of 50, I would not be thinking deliver between 35 and 36 weeks. However, I would want to repeat bile acids in this woman because, as I mentioned earlier, I am concerned about women with cholestasis plus another diagnosis. And in the national cohort study that we performed, the UCOS study, the second one after the Swedish study, something we did note was of those pregnancies complicated by stillbirth, a sizable proportion had coexisting gestational diabetes or preeclampsia. And the other group I worry about are women with coexisting inflammatory bowel disease. So that does, all those coexisting disorders raise a bit of a flag. So although I wouldn't say 35 to 36, I would consider maybe delivering a bit earlier, but maybe past 36, closer to 36, 37. But I would talk very much with the diabetes team as well, and just watch how she's doing. But she has multiple metabolic derangements that are worrying.
Absolutely. Doctor, what is your take on fetal monitoring in these patients? You have a lot of work besides the conventional monitoring we do.
Yes, I think it's very difficult. As you will know, for ICP, it is very different to other disorders. There is no evidence that performing the routine monitoring such as CTGs predicts women likely to have adverse outcomes, and it may falsely reassure. But a lot of women are reassured by having it at the time. So I tend to have a very sensible conversation with the woman. And if she's very anxious, and certainly those who've had a previous death or adverse outcomes may want to come more regularly, and that's fine. But I do tell them it does not tell us that anything is okay the minute the monitor comes off you. I think monitoring bile acids, if you are able to do that, is quite helpful. And I do tell women to think about their movements. So this again is anecdotal, but I have a tertiary practice where I see a lot of women in the UK and some internationally who have had stillbirths, and talk to them and then talk about subsequent management. And a not small number of women will say they think they had increased movements prior to a death. So I'm not convinced that ICP is necessarily associated with reduced movements. It may be changed movements. So I would certainly try to involve the women as much as possible. And I do say to them, just come to the hospital anytime you're worried, we'll check you immediately, because they're so hard to predict. They're very difficult. So I cannot tell you a good form of fetal monitoring because we do not have it. But we are trying to work on that. From the fetal ECG work, we do wonder whether there may be some Herald type alterations in fetal ECG parameters that could predict the more high-risk fetus. So we are working with the fetal ECG monitor companies and mathematicians to see if we can develop algorithms. But in truth, we don't have anything at the moment. We will publicize it as soon as possible if we do.
Sangeeta, can I come here for a second?
Yeah, sure, ma'am.
Yeah, Dr. Catherine, I would like to ask you about the fetal monitoring. The modalities which we have by and large are the daily fetal movement record by the mother and doing a non-stress test. We in India, we do not have facilities much for the computerized CTG. What would be your take on using computerized CTG in these women? Do you think it will have any add-on benefit?
I have to give a slight caveat to remember I'm not an obstetrician, but in my experience, the answer is it doesn't really give a lot of additional benefit. I think it may give psychological reassurance to the clinicians and the woman when it's being done. But in truth, no. And if you were to use scarce resources on deciding the best way to monitor her, I think it would be better to have a single bile acid measurement.
So taking it further, she followed to us at 35 and 36 weeks. Now at 36 weeks, there was a sudden rise in the bile acids to the order of about 100. And her blood sugars were also not too good. And we all know with the COVID going on, because we were planning her termination. So we had asked her to get a RT-PCR for COVID-19 done. And unfortunately, it turned out to be positive. So she's now an asymptomatic COVID positive. She's a severe cholestasis and she's a diabetic, not very well controlled on diet. So Dr. Asmita can give us some thoughts before you come to it, Catherine. There's no better person than Dr. Asmita at the moment, because she's heading the team of obstetrics, which has managed maximum number of pregnant COVID women in Delhi. So Dr. Asmita.
Yeah. As far as the obstetric cholestasis is concerned, I think for IHCP with bile acids more than 100, she does need the delivery. At 36 weeks and 4 weeks, but she's also a diabetic. So with the diabetes, that too a not very well controlled one, we do expect some problem with the fetal lung maturity and little bit delay in the fetal lung maturity. So anyway, at this period of gestation, she also needs an
dose of a steroid before we think of delivering her. So the point is, so our first task will be to give her a course of steroid, monitor her sugars and control the sugars till we give her steroid. Here I would like to have a comment from Dr. Catherine, how urgent it is to deliver when she has a bile acid more than 100. Do we have 2-3 days time? Do we have some more time till she becomes COVID negative? I mean, how do we, what is our, should be our policy here?
I think this is a very difficult case. My instinct would be you wouldn't want to leave it for too long. And if you're giving steroids, I'd be tempted to bring her in to monitor her because I think she could be really quite high risk if her glucose goes very high. And of course, although she's asymptomatic COVID, it's still a concern. And it could be making her slightly worse, especially in terms of the diabetes. But my instinct is you want to deliver her reasonably soon. It doesn't have to be immediate. You have time to let the steroids work, but I would watch her very closely while you're giving her the steroids, because I think they are almost an additional risk factor because they'll make her more hyperglycemic and then more at risk. They're very challenging, these cases. But when the bile acids are over 100, she's now in this high stillbirth risk group. So I would want to get her delivered as soon as sensible and safe.
Yeah, our concern here would be she's an asymptomatic COVID positive woman. In a by and large, a clinical implication of her being asymptomatic, we do presume she has a lower viral load and not much problem. But I would prefer to have my physician come into the picture at this point and let me help. If any sort of an indicator of a severity of her viral load in a woman can help us in deciding whether what are the maternal risks associated with this induction or cesarean, whatever we decide. Because operating on a woman who is COVID positive is also likely to have a significant morbidity in the mother. So it's a little tricky situation with balancing the risk of maternal versus the fetal risk. And probably we need a multidisciplinary team, appropriate counseling of a woman, and then make a decision. I'm not very sure if we do the markers of sepsis like a CRP or neutrophil lymphocyte ratio or the procalcitonin. Will they help us in any way telling what is the maternal risk of induction? Because she is a diabetic with a little bigger baby. So the possibility of her ending up with a cesarean are quite significant. So I think it's a little dicey decision with a balance between both maternal and fetal risks. What would be your take about that?
Oh, I absolutely agree. MDT management. Her oxygen saturations will be very important. If you have any concerns, I think it's fair enough to image her lungs, to do a chest x-ray, and the markers of severity and inflammation. Ensure she doesn't have any markers of hyperinflammation associated with COVID. I suspect there is a spectrum of response. And so some people, but if she doesn't, I think you have to individualize it. Of course, if there are concerns about maternal deterioration, that would change what you do. Definite multidisciplinary management and very close surveillance of both, but if possible, delivering within a few days.
Well, thank you,
The one thing, I don't know it's helpful with this type of case, but as a generalization, I find that women with ICP labor well. And I think it may partly relate to bile acids causing the myometrium to be a bit more contractile in the same way as the influence cardiac contraction. So although she has a bigger baby, there hopefully is a chance she may labor a bit better than your average woman with a baby that size with GDM. But of course you can't know, and you have to cover all contingencies.
Thank you, Dr. Catherine and Dr. Asmita.
Dr. Sangeeta would like to know outcome of this patient.
Yeah, Dr. Asmita, we had waited for a week in this patient. And finally, after discussing with the patient, she opted for a cesarean section and a 3.7 kg baby was delivered, and both the mother and the baby were fine. There were no maternal or perinatal complications.
How was her COVID situation? Was she given GA or a regional anesthesia during cesarean?
She was managed with regional anesthesia.
Yeah.
And as I told you, there was no post-operative complication also in the patient.
Sangeeta?
Yes, ma'am.
I think let's check with Catherine if she has more time, because it's 5:30.
Sure, ma'am.
Hi, Catherine.
Yes,
And
I have a little.
We have lots of questions.
Are you happy to carry on?
I can carry on for another 10 or 15 minutes. Yes.
15 minutes. All right. So, Sangeeta and Jyoti, could you just, be very short with this?
So we like all our discussions also, we'll just keep it to the point so that we can finish the next.
So let's have Catherine's viewpoint, yeah?
So she's a fourth case that we're talking. She's second gravida, para 1, 26 weeks. She came to us with symptoms of pruritus. Considering that it could be IHCP, we did her LFTs. They were found to be perfectly normal. So we gave her symptomatic treatment and we sent her back home. She came back to us 2 weeks later, symptoms still very persistent. We did the LFT again for her and the LFT was perfectly normal. So Professor Catherine, what I wish to know from you is that, should we consider, because we all are so obsessed with IHCP, any pruritus, we think this is going to be an IHCP. So are all pruritus? Second thing that I need to know is that in case we are really thinking of an IHCP with a pruritus which doesn't have any lesions on the body, how frequently should we do our LFT or liver enzymes, and when do we actually need to stop doing it if we find it to be perfectly normal?
It's very difficult because people are so variable. All pruritus is not a precursor of ICP. It is too common. Having said that, as I mentioned when I was talking about the pruritogens, autotaxin and progesterone sulfates do rise in normal pregnancy, but they rise further in ICP. So I think maybe this explains, I suspect, a tendency to mild cholestasis as a tendency to mild hypercholesterolemia is a normal adaptation to pregnancy and probably of an evolutionary advantage. And unfortunately for women, associated with that is probably a normal tendency to pruritus for some women. The problem is when it becomes pathological. And of course, for some women, when it is so severe that they can't sleep. So no, not all pruritus. However, pruritus is associated with high bile acid, which can be a risk. So then, as you say, the difficult decision is how often to screen. I think 2 weekly from 26 weeks is very reasonable. If it gets worse, maybe thinking of bile acids as well, if you can do them. As I said, if you can only do them once, 34 weeks is probably the right time. It's tricky. I feel very sorry for some of these women because there are the occasional women who are very, very distressed by it. But at least doing them fortnightly and maybe from 32 weeks weekly, you will be able to reassure her and reassure yourself that you're not missing anything.
Thank you so much. And Dr. Manju Khemani, I would like to get you over here inside. Like as Professor Catherine did say, that sometimes the bile acids may be there, but we have not estimated they may be responsible. So what we have seen in our clinical practice, many people with LFTs normal, even if the enzymes would be normal but pruritus, they do give them UDC and they do respond. And the second thing I want you also to address, Dr. Khemani, is that in the COVID times, when the patient has pruritus and they refuse to call any of these people to take the samples from the lab and they ask you to give them UDCA, are you really, would you say, is it right to give them UDCA, thinking that it could be pruritus or maybe bile acids may be high? And the first question, both of them for you, Dr. Khemani.
So Jyoti, what I would say that, if our enzymes are normal, bile acids are normal, how is deoxycholic acid going to work? Every drug has a placebo effect 30%. So I don't think it is right to put her on USTA, even though it is safe. But why should we give a drug unnecessarily? Do you agree with me, Dr. Catherine?
As a generalization, yes. But as I said earlier, there is the occasional woman who is so distressed, or if she can't sleep, or if it's affecting her mental state, then I'm more flexible about those cases. But I think as a general rule, as I said earlier, above all, do no harm. And although the safety data are good, you want to avoid drugs if you can. Your difficult situation is if you can't get any measurements done. I think it might be better for the woman to make one trip to a hospital to have some measurements done. And then at least she has some science to support the giving of the treatment. But it's very difficult. And I know that in India, you're having such troubles with COVID at the moment. So I think you have to be pragmatic. For most women, I would not give it, but for those who are very, very distressed, or if there is a clinical concern that you can't get the bloods done, I might not do that.
Or maybe, we can try antihistaminics or, some local lotion containing menthol, to give her some soothing effect rather than, giving her a drug, when we don't have any proof. Because see, Utka is going to reduce the bile acid and that's how it's going to help. But if the bile acids are not raised, Utka will only have a placebo effect. I mean, this is what I feel. I could be wrong. You have more experience.
No, you're absolutely right. I was still thinking about women where you have no measurements. If you know the bile acids are normal, I would very rarely give it. As I said, only the very exceptional case where it's really affecting her mental state.
We go ahead with this case. Now she's 32 weeks and luckily or unluckily, we would say we did get elevated ALT for her. So we were fortunate we could start her on the UDCA and we found that the bile acids remained less than 40 on a monitoring that was done weekly. She continued and she had a gap in between 2 weeks, and when she came back to us at 37 weeks, we found that itching was much better. Her liver enzymes were far good, 50 and 46, and the bile acids at this time was 28. Ultrasound was perfectly normal. So, Professor Catherine, would you advise that we deliver her? Because the bile acids have never gone above 40. They've always been below 40. She's 37. Would you consider her delivery now or should we take her till 39 weeks?
I think it's reasonable to continue monitoring bile acids and take her to 39 weeks. And I would probably think somewhere around 39 weeks it's reasonable if she delivered, but maybe she will go into spontaneous labor by then. I wouldn't let her go too far post dates because bile acids do continue to rise. But I think, yes, I would wait until 39.
And Dr. Kimani, had the bile acids been somewhere 58, would you have considered delivery now? Would you also have taken her up to 39 weeks? Because she comes in between 40 to 100 category, which is associated with increased neonatal and adverse outcomes.
Okay, I'm actually confused. Dr. Catherine, I wanted to ask you this question. See, just read, 2021, Fetal Medicine Society's, guidelines, and they just divided it into more than 100 and less than 100. When it is less than 100 bile acid, they say you can deliver anytime between 36 to 39. They don't have the concept of 40. So I'm really confused whether I should follow the 41. But yes, if everything is fine, and if it is not crossed more than 100, I would still like to carry her till 39 because induction has its own problems.
Yeah, I agree. If they're under 100, I think it's reasonable to go to 39.
Okay. So I think what we have achieved from here that if it's less than 100, it has never gone above 100 throughout a particular monitoring. We can take them up till 39 weeks. That's what we're going to take. And if it's more than 100, yes, then we consider delivery before 36 weeks or at 36 weeks. So thank you, Dr. Kimani. Now we're going to move on to the case 5. And that is a primary gravida 20-week singleton pregnancy. She came for a review for an anamnese scan. And when we did a clinical examination, we found there were plenty of scratch marks on the hands and the tummy. We did review her history. There was no reason why she should have had so much itch, past history of liver disorders, jaundice, dermatosis, or progesterone ingestions. Her liver enzymes were quite raised, and so was her bile acids, which was found to be 36. So what we need to ask you, Professor Catherine, at 20 weeks, we say IHPC normally starts somewhere about 32, 34 weeks. If at 20 weeks a patient presents like this, can we label her as an early onset IHCP? And do we need to do any other investigations actually to exclude or to come to the diagnosis that this actually is an IHCP?
I think you can call her cholestasis and with early onset, yes, because she has cholestasis. And am I correct? The bile acids were raised as well, weren't they? But mildly raised, mildly, yes. So she has cholestasis and it is early onset. She is the type of person, it wouldn't surprise me if she has genetic susceptibility. I think you should think about other causes, but it's likely to be a cholestatic process. So in this type of woman, I would think about, well, I would certainly find out if she has taken any medication that could have caused her to have developed cholestasis now. If she'd had fertility treatment, was maybe taking progesterone, that could also increase the likelihood of developing early. Definitely take a family history as well as a personal history of any hepatobiliary disease. Often people will tell me about a father or an aunt with gallstones, and sometimes a father or an uncle, maybe with what they say he died of cirrhosis, and they said it was alcoholic, but he didn't really drink. And then you realize that maybe this is a familial susceptibility. So certainly I would also, yes, so I would screen for hepatitis C, autoantibodies, definitely. Anything else that seems logical to screen for, and gallstones. And then watch her closely. Some women will declare themselves as having other rarer liver conditions, but most common things are common. She's more likely to have early onset cholestasis because of genetic susceptibility.
Do these women have more adverse outcomes as far as the pregnancy is concerned, or as far as the baby is concerned, if they start off much earlier? Should we be more careful for them?
It's difficult to answer. From the statistical analyses we've done, we have not shown that. However, if a woman presents very early, considering what I said about area under the curve of exposure, it's the early onset women who tend to have more of the spontaneous preterm labor, not surprisingly, at earlier gestations, because they're the women who will have been exposed. So I think you have to think about that in this group. But also if they present earlier, they have more time to become severe.
So Dr. Sohani, I would like to get in over here because during the talk, Catherine did say about the long-term complications of the women with IHCP. So when these IHCP women do come to you at 6 weeks postnatal checkup, so do you have any strategy to be able to look in for the long-term complications, or something? Are you really bothered? And how do you go about these patients at 6 weeks postnatal counseling?
Yes, yeah, I think they have to be, the LFT has to be checked, and all the long-term complications, what Professor Williamson has already very well enumerated, have to be counseled about. And future pregnancy, she has to be counseled that there is a recurrence risk of around 60 to 70%. She has to preferably avoid estrogen containing OCP. But can I take the opportunity to bring Professor Williamson on some more points, some more issues here, please? Take the opportunity to have her opinion. I think we see ICP quite not so uncommonly in IVF pregnancies, and quite early onset as well. So how much would you blame the progesterone supplementation, what we are giving to these patients? And second thing is, like a case I remember very clearly, that she was a post-thyroid cancer patient, cancer survivor, then she conceived through IVF, and she had very early onset cholestasis, as early as 12-16 weeks. So first we blamed it to the progesterone and we stopped it, but she continued. And with the UDCA, her LFT and the bile acid came down. She also went on to develop GDM, preeclampsia, FGR, and in the third trimester. So what are your, I think, views on IVF and progesterone supplementation and the incidence of ICP?
If you don't mind, the next case actually also addresses the same question. So I'll just go through
all right.
the answers together for the particular one. So the next case, Dr. Sangeeta.
So I invite Dr. Uma Ram to discuss this case with Dr. Catherine. She's a primary 30-week singleton pregnancy and IVF conception, and again had complaints of itching with elevated liver enzymes and bile acids, which was suggestive of IHCP. When the history was reviewed, there was no family history of IHCP among the sisters, no past history of liver disorders. However, she had been given progesterone in early pregnancy and still is on weekly injectable progesterone. Next slide, please. So, Dr. Catherine, we'd like to know what are your thoughts about this unauthorized and excessive use of progesterone? Is it responsible for increased incidence of IHCP?
I think it contributes. I have seen a number of women who have had fertility treatment of various sorts, who are on ongoing high-dose progesterone, who present with quite severe cholestasis in early pregnancy. And I've suggested even a rationalization of the progesterone concentration that she is being given to the IVF doctors, and considering when it can be stopped. And often when a woman stops the progesterone, her cholestasis gets better. Although I think this is a woman who is susceptible to cholestasis in late pregnancy, but I'm sure that this is the case. I've seen too many women with this story for it not to be the case.
Okay. And is there any, sorry, please carry on.
Sorry, Sangeeta. Professor Catherine, I wanted to ask you, there are two types of progesterone, right, that are used, the injectable in this case and vaginal progesterone. From the little small studies that I have seen, for some reason, vaginal progesterone seems to have a greater impact than the injectable. Is that true? And if so, why do you think there is a difference?
That is an incredibly good question. Also, there are some reports of oral progesterone really having quite a considerable effect as well. The truth is, I don't know the answer. I think it's a really interesting question. And I'm trying to think of an answer as we talk about it now. I'm trying to think, with oral progesterone, I was thinking, could it relate to first pass through the liver and maybe an impact on gut signaling and liver signaling? That makes sense to me.
Mm-hmm.
Vaginal compared to injected, I think it's a fantastic question. I will go away and think about it. I can't think of a good answer right now. It's very interesting.
Yeah, there's one small study where I saw this, but it was only an abstract, so I'm not quite sure. And the reason it got me thinking is we have a large number of pregnancies, as Dr. Sohini mentioned, in India, where progesterone is used very liberally. We also have a very high incidence of insulin resistance and gestational diabetes. So it may actually be a good idea if we could all get together and try and see if we can put some data that may help, because the numbers you will easily find in India.
That is
just
very
a thought.
interesting. I mean, I would love to talk about that. Maybe we could speak offline about that.
Yeah.
And it would be fascinating to try to establish the extent to which the progesterones are absorbed and whether they're sulfated, and whether that in turn could influence bile acid homeostasis and maybe glucose homeostasis as well. I have a PhD student working on the progesterone sulfates at present, and whether their concentrations vary in women susceptible to gestational diabetes. So it could be a very, very interesting thing to study.
Yes, yeah. Thank you. Thank you.
And Dr. Catherine, one more question I have. If you have time, we can ask you that. Otherwise, we can wind it up now.
I think we'll wind
up. Okay.
And I have a question then.
We have lots of questions from the audience. If we quickly go one by one, Ranjana, because otherwise...
Sure.
Yeah. It was a mesmerizing, Professor Catherine, and I think none of the lecture till now has cleared IHCP so clearly as you have done it. So thank you so much. So I think I have bombarded with the questions, but I've picked a few which have not been covered. The first question is, like in a twin pregnancy, are the cutoff values with bile acid is the same or a different in the singleton?
I think your question is so important. It's something we would like to address. Unfortunately, a grant application we submitted to study this was not funded, but we're trying to find a way to do it anyway. There has to be a difference. The complication rates are different. What we would consider to be normal term is different. There must be a difference depending upon whether there's zygosity and so on. So I think this is an understudied group where we need more data. I can't give you clear-cut data at present, as anecdotally, it wouldn't surprise me if the risk of hypercholenemia, the high bile acids, is maybe slightly higher, and the risks may be slightly higher, but I truly don't know. We are going to try to find out. So I hope within 2 or 3 years, we'll have some answers.
Thank you. So the next question is, like usually the intrahepatic cholestasis happens after 28 weeks, and we do the screening for diabetes between 24 to 28. Do you recommend we repeat blood sugars once the intrahepatic cholestasis we diagnose? Because it seems if it's related with that.
I think, again, it's a brilliant question. We tried to address this. There's one paper that Marcus Martineau is first author on, where we at least studied women who had developed cholestasis before their GTT and developed it after. And maybe no surprise, those that developed it before were the ones where you could find an increased rate of gestational diabetes, which would tie in with the hypothesis. In terms of screening after, I think maybe for the women where you have a high index of suspicion, it may be worth finding some way, or maybe if not screening, maybe just asking them to do some capillary blood glucose to see if there's a difference, or if you see the baby is becoming larger. I would defer to diabetes experts. It's something I think maybe should be considered. One risk is we don't quite know what to do with screening the screens that are positive for gestational diabetes outside the context of ICP. Yes. So the question is, how far do we take it? So I don't think we have good guidance that tell us we should do it for all cases now. But if there's a woman where you think knowing might make a difference, that's no bad thing. Another question women often ask me after they've been to the internet is, should they be on a very low fat diet? And I always advise them not to be on very low fat, but maybe a sensible diabetic type diet,
Yes.
which is good for the cholestasis as well.
Okay. Yes, this was also one of the questions. What kind of a diet a woman should have? Thank you for answering that. Another very interesting question, when you have an intrahepatic cholestasis and your UDCA is not working, can we add rifampicin? If yes, then what is the dose? And the third most important thing, we all know rifampicin is hepatotoxic. Does it affect the liver enzymes, or any differences monitoring?
Yeah, I'm looking forward to the results of the terrific trial I mentioned. But if you are not a part of the trial, certainly what I have done historically is I would have used ursodeoxycholic acid as first line in women who don't respond, who have severe disease and where their transaminases are not too high. And if you ask me for a threshold, a psychological threshold would be about 150. Then I would try rifampicin, but I would warn the woman that her urine, her tears are all going to go an orange color. And she has, I would say, a 5 to 10% chance of an idiosyncratic drug reaction. Now, the cases I have experienced this in, I think I can count on 2 hands, but for all of them, I stop the drug and the transaminases go back to where they were before. But I wouldn't start it if the transaminases are much higher than 150, because I worry in those cases an idiosyncratic drug reaction really might become more harmful. But this is really quite anecdotal. I'm not giving this advice on using a lot of extensive data. It's more what I do from my own experience. But I think that's a sensible approach. There are some women who really respond. You saw the graph. It's about 1/3 of women, but for that subgroup, it really works.
Thank you. And the cutoff to start UDCA is 10 or 40?
I think personally, for most women, we should probably shift our upper end of our normal range to about 20.
20.
do we want to start her? So then you have to think, and there are no good guidance at present, and I would almost follow any guideline that is within what I think is sensible. I think for those with bile acids over 40, where you have enough time to prevent a preterm birth, it's sensible to start ursodeoxycholic acid, unless you're running a trial, in which case I would follow, if you're happy with the trial protocol, follow that. For those under 40, then maybe people should consider, do they want to try to prevent a woman going over 40, and will that be of benefit? Yeah. Maybe we need a good trial to give us the answer to that, which we don't have yet.
Okay, thank you. And, we are into an era of a COVID pandemic, and we all know the transaminases, they increase during this time. And how is the bile acid is only criteria to see when intrahepatic cholestasis happen, or there is some other criteria to it?
Are you asking in the context of COVID?
If a patient has a COVID and her transaminases have increased, and now she has an itching, we suspect is an intrahepatic cholestasis. How to differentiate between the two diseases? Is the bile acid is only the criteria, or how to go about it?
It's tricky in that I think cholestasis, as with all major obstetric disorders, it's not the endpoint of one pathology. And I think a lot of people, it's almost a multi-step set of hits. So somebody may be quite genetically susceptible. Then if they have a singleton pregnancy, the pregnancy hormones are at a certain level to unmask their susceptibility. They have a multifetal pregnancy that may be higher, so they're more likely to get it. Then if they take an antibiotic, that makes them more susceptible. If they develop an infection, it makes them more susceptible. And one of those infections could be COVID. So it's tricky. It could be the hit that tips somebody into becoming symptomatic cholestasis. And then maybe what matters for us, if you can manage the mother in terms of the transaminase is fine, but then you think about fetal risk. And do you want to know the diagnosis and maybe the bile acid concentration to decide, is this a woman at risk of the adverse outcomes or not? So it's, in a sense, it's nuanced, and it's in some ways the joy, but also the challenge of being clinicians is trying to sift out the differential diagnoses.
Can I just ask here one question, Catherine? So you see, by definition, it is cholestasis, and there is no inflammation in the liver. So why do we have, see, if you do histopathology, then you are supposed to see only cholestasis or inflammation in cholestasis of pregnancy. And then why do you have raised enzymes? And if they get raised, then why GGG doesn't increase?
I can answer that up to a point. I didn't go into great detail about the bile acid homeostasis, but when you think about the intrahepatic circulation, there are the transport proteins I told you about on the bile canalicular membrane going into the bile ducts. There are also influx proteins on the other side of the liver. And I actually think some people have mutations in the genes that take bile acids out of the liver, and that's the group where bile acids will accumulate in liver cells and cause damage. There are some people who have abnormalities at the level of the gut or coming into the liver, and they are maybe more likely to have bile acids in the blood, but not have the transaminases so high. So I think probably as we learn more about the genetics, and I didn't go into all the detail here, we will subdivide our women, and we really will find it's the endpoint of a number of pathologies. And some of the genetic pathologies cause high bile acids and not high transaminases, and others cause high bile acids and high transaminases. And then there are some people maybe who are much more susceptible to hepatocyte damage for one reason or another, and so their bile acids aren't so high, or they have a very efficient kidney at excreting the bile acids. So I think it's a bit multifactorial, and maybe what really matters is individualizing the risk for that woman. Is that helpful in answering that?
All right. Okay, thank you.
As you said, the bile acid better we measure throughout the day, not the fasting one. Is this a particular time you will say it's 2 hours after the meal or any time?
I think the simple answer is any time. It's interesting. The two people in my team who were first authors on that paper, Alice Mitchell and Carolina Vardia, both wanted us to write in the paper, do it 1 hour after lunch. But I did say to them, if you look at the whole day, they're raised for the whole day, and people have to have a pragmatic, sensible answer to look after their poor women who might not be able to arrive at 3 o'clock in the afternoon. So I think any time in the day.
So I think that's a wonderful take-home message, because till now we were all doing the fasting ones, you know, so that's a good.
Can we stop here, Angela, now?
Just one last, and which is, I thought is an interesting question. Somebody has put a question.
Sure.
As you have said, then IHCP has a genetic predisposition. Can these women go for a transplant for the liver if their family needs it?
Oh, you mean, can they be a donor?
Donor, yep.
Oh, it's a very good question. Well, I think they have to be aware that they have this susceptibility. And so as a transplant liver, the recipient will be receiving a liver that is susceptible to cholestasis. But ironically, we wrote up a case a few years ago of a woman who was a transplant recipient who developed cholestasis in her pregnancy. And we found that the transplant liver had a mutation in one of the genes I told you about. So having said that, maybe it's better to have a liver that is susceptible to cholestasis in pregnancy and when taking some drugs, but will keep you a lot more alive than the disease for which you need the transplant. So the important thing is they know, and then the hepatologist and the family can make the decision.
You know, the recent AOGD guideline says there's also a question that intrahepatic cholestasis patient to be delivered at 37 weeks, as the chances of stillbirths, you know, are higher between 37 and 39. But I think your lecture says very clearly you go by bile acids, not by the period of gestation.
I think that was a very good bulletin, the bulletin they put out. And they were a bit, yes, and they gave, I think, a week or so later than I would say, this is my opinion.
Yes.
We will see what the UK guidelines say. I suspect they will say something very similar, but they are not quite out yet. But the new Green Top guideline will be out soon. So yes, the guidelines may differ by a week or so. And then as clinicians, we make our decision about what we think.
Anita,
we have to
thank you very much.
The still questions are coming, but I think we can't take so many.
So is it possible, Catherine, that perhaps we can send them to you, and if you don't mind, at some point, if there are some questions which are unanswered and we can't address it, that can we?
I will do my best. I will give a slight warning that I will truly do my best, but I receive over 100 emails every day. So I will really try. I'll try to do it.
Thank you. Then figure
You
it
know,
out.
you gave us so many good tips and we are so happy. And I think we don't mind you come back and give us a lecture again in 3 months just to refresh our knowledge again.
I will be delighted to do that. And I would actually love to talk to anyone who's interested in an interesting project or thinking about bile acid delivery.
So thank you very much. I mean, I'm sort of just formally thanking you, but I think that the fact that all of us have been absolutely glued to your every word and including all the delegates sort of speaks for itself. So thank you very much. I'd like to also thank AOGD and NARCHI, who were our academic partners in this. So thanks for that. The discussants who, I think, I mean, I need to tell you, Catherine, that they really are the sort of leaders in their practice in Delhi. And I really appreciated the fact that they were so open to, asking questions. And I really appreciate this about all our discussions and things. So thank you very much for that. The delegates for staying with us for as long as they did. And Abbott, our partner, and in particular Ritika. So on behalf of the whole North Zone team, Shelley in particular, who's been sort of behind the scene. So on behalf of Ranjana, Jyoti, myself, Asmita, Sangeeta, all of us, Anjala, thank you very, very much, and hope to see you again soon.
Thank you, and thank you for inviting me.
So there were more than 900 logins.
More than 1,000.
More than 1,000.
Fantastic. Thank you.
Thanks. And goodbye, everyone.
Thank you, Asmita, and thank you, Achala, for all the, getting together as team.
Thank you,
very
Ranjana.
much, Catherine. It was a wonderful session. Wonderful.
Really.
Thank you.
And we always feel
Very,
so
very
satisfied when you learn, and it's just been the genetic aspects really interest me. So I'm looking forward to another talk.
Great. Well, we will have more coming out on that soon. So thank you.
Okay.
Thank you.
Thank you, Emma.
Bye.
Okay. Thank you, everyone. Bye-bye.
Bye.
Bye. Excellent. Wonderful.
Thank you. Good.
So thank you, all the discussants. You did a wonderful job, really. Excellent teamwork. How did you like it?
Wonderful.
It was very
good,
nice
very
and very
good.
useful, Ranjana. Very good.
Chalo.
Ranjana, so much, more than what you read in the